Good evening, everyone. My name is Pierre Lemire. It's a pleasure. I'm the CEO of Kent Imaging, and on behalf of Massachusetts General Hospital and Kent Imaging, I'd like to welcome you to our webinar on oxygen matters and wound healing. Before we get started, we just want to point out a quick logistics, which is in the bottom middle of your screen. You have a Q&A button. So if at some point through the presentation, you have a question, feel free to type it in there. We can answer it just by text through the presentation, or if it's not covered by then, we'll cover it in the Q&A session at the end. So we have about 40 to 45 minutes of material and then a 15-minute question and answer session in tonight's webinar. Next slide, please. So it's my pleasure to welcome Dr. Adam Landsman, who is a practicing physician at Massachusetts General Hospital. Dr. Landsman has been using our device for over 4 years and has provided valuable insight and feedback into the product. And we're very excited to have him today to speak on some of the technical aspects of the product, as well as how it can be used clinically to improve and assess oxygenation in wound care. Also during the presentation, we're going to have a video presented by Dr. Jeffrey Niezgoda, who has been using the Kent device, also the Snapshot device, in his clinic in Milwaukee. So we're really excited to have that as well, to show you a real view of how the product is used clinically at a real practice. So we're very excited to have you on board with our webinar, and I'll pass it now to Dr. Landsman to take us through. Go ahead, Dr. Landsman.
Thank you so much for having me. It's a pleasure to have an opportunity to speak to this group. And I'm very excited about the Kent imaging technology that we're going to be talking about. I started using the Kent Snapshot device about 4 years ago, as you heard. And when we first started using it, it was a lot of information that we weren't sure how we would use. And now that I've had all this experience using it, I can say that it's really changed our approach to wound care in a way that I never really imagined would be possible. So some of the things that we're going to talk about tonight are whether oxygenation really matters. And so we're going to look at the importance of tissue oxygenation in the wound and how to evaluate that to make some predictions about potential for healing. Also, as part of that, I want to distinguish between oxygenation and perfusion. We're going to talk a little bit about that. Then we're going to talk about the science behind this infrared technology. So I want to try to help everybody to understand exactly what it is that we're talking about when it comes to near infrared light and why it makes a difference, the type of light you use to make this determination. Seeing is believing. We're going to have a technological demonstration that will be from Dr. Niezgoda, and then we're going to have some case studies from myself. And then finally, we're in the era of COVID suddenly, and this type of technology just might be the perfect thing to supplement what you're already doing in your clinical setting. So let's go to the next slide. So when we're looking at a wound like this is a complicated wound, and it's not obvious what's going on here exactly. Are we looking at necrosis? Are we looking at the presence of biofilms? Are matrix metalloproteases an issue? Is there perfusion? Is there oxygenation? Where is this exudate coming from? Is this wound infected? Do we need to regulate mechanical pressures, or is this something else that's going on here? So the idea behind the near infrared spectroscopy and the idea of measuring oxygenation of a wound is really coming down to what additional information can we get in order to assess this wound. Okay, next. So really this is coming down to a balancing act. We have to weigh the patient's ability to heal based on a variety of different things, many of which are out of our control, things like their age and the mechanical environment of the wound, as well as their glucose control and vascular status and their neuropathy. And then all the confounding factors, the things that we might be able to control: infections, activity levels, and even their wound chemistry and perfusion all play a role. And it's this delicate balancing act to try to keep all the balls in the air and try to get the wound to progress towards healing. Next. So it's really hard to look at a wound and know exactly what's wrong with it. It's not like bone. If there's a fracture, you can get an X-ray, you can get a bone scan, you can get an MRI, you can get a CT, and you have a lot of different tools to say that bone is fractured and that bone is healing or not healing. But when it comes to wounds, there's so many aspects about a wound that we don't have all the diagnostic tools that we would like to have, like we do with other things. So for example, if we suspect biofilms, we can do wound cultures. We can do mechanical pressure measurements. We can do Semmes-Weinstein for neuropathy. We can get x-rays to determine if there's osteomyelitis or gas in the tissues. We can do thermography as an indication of inflammation. And we can measure pulses, which are a macroscopic measure. But what we can't see by looking at it or using any of these tests is what's going on that microscopic level. Is the wound receiving the growth factors and exchanging oxygen and doing the things that we know wounds need to do at the microscopic level in order to heal? Next. So there are a couple of guiding principles when we talk about wound healing. And, you know, one of the cliche sayings that we have is no flow, no toe. And essentially what we're saying is the wound has to be able to receive the nutrients and oxygen that it needs in order to heal, and it has to be able to get rid of the waste products. So no oxygen, no healing. Next. So because of this, oxygenation matters. And I think what we should do now is just briefly go into why oxygen matters and how to distinguish between oxygenation and perfusion. Okay, next. So tissues consume oxygen to produce energy. It's a cornerstone for how wounds are going to heal. And the oxygen is carried by hemoglobin, which is a protein that binds it, connected to the red blood cells. And as the red blood cells flow past different areas, it releases oxygen into the tissues where it's needed. And so tissue oxygen saturation is really that percentage of oxygen-bound hemoglobin that reaches those tissues. So when we look at STO2, we're really looking at the tissue oxygen consumption and delivery. Okay, so circulation can be broadly divided into macrocirculation and microcirculation. So macrocirculation is what you can feel. Those are the pulses. Those are the signals that we get from Doppler. These are the major flow between the arteries and the veins. Now the microcirculation is really the transition from vein to venule to capillary bed, and then all the way into the arterial and then back into the artery. Or in most cases, it's the reverse direction: artery, arterial, capillary, venule, and then vein. So what we're really looking at is we want to know at that level, at that tiny, tiny level where the exchange of oxygen is happening, what's happening, where is the oxygen going, where is it coming from, and what's happening. So this is where near-infrared spectroscopy comes into play, because it allows you to see the transfer of oxygen. Okay, next. So when we talk about perfusion versus oxygenation, you can think about perfusion as the flow into the area, but the flow into the area doesn't always tell you what's oxygenated and what's not. So for example, in this example with a train, so the tracks are the vessels and the train are the red blood cells. So you can tell when the train comes in and out of the station. That's perfusion. Okay, next. But what we can't tell is we can't tell who's on those train cars. So the people are like the oxygen. So when we look at tissue oxygen saturation, what we're really saying is how many people are on that train? How much oxygen is actually getting to those tissues on those red blood cells? That's the difference between perfusion and oxygenation. Next. So perfusion does not equal oxygenation. We can have trains coming to the station and leaving the station, but not dropping off passengers. Next. So no perfusion means no oxygenation. Next. And next. So what we're looking at is near-infrared spectroscopy measuring actual oxygen saturation. So we're looking at oxygenation, which is a sort of a higher measure of perfusion. You can't have oxygenation without perfusion, but you can certainly have perfusion without oxygenation. So the technology allows us to calculate the ratio between oxygenated and deoxygenated hemoglobin. Okay, next. Okay, so when we look at a pulse oximeter, right, what we're really looking at is oxygen saturated blood vessels, or oxygen saturated red blood cells rather. And it shoots all the way through the finger from top to bottom. And so you're used to seeing numbers between 90 and 100 because you're measuring both sides of the equation. You're measuring the oxygenated and the deoxygenated, and it's giving you those ratios. So if the blood is really well oxygenated, it's going to give you a really high number, close to 100%, because you're looking at mostly arterial flow. Okay, next. When we look at near-infrared spectroscopy versus TCOM, now TCOM is measuring free oxygen. So this is oxygen that's already been offloaded from the hemoglobin, and it's sitting in the tissues itself. So this is free oxygen in the tissues. When we look at near-infrared spectroscopy, we're looking at bound oxygen. So again, these two are similar. They have a direct linear relationship. You can't have increase in tissue free oxygen without having a proportional change in the near-infrared spectroscopy measurements. So they are a linear relationship, right? There's actually if you have one, you can simply calculate the other, but they are not exactly the same. So they mirror each other. When TCOM changes near-infrared spectroscopy and measurements change the same amount. And so they are not exchangeable, but they are parallel. Okay, next. So again, it's using the transportation analogy. TCOM is the passengers waiting for the taxi. They're surrounding the taxi. And near-infrared is the passengers are in the taxi. Next. Okay, so how do we get that specific information from near-infrared spectroscopy that we're not getting from pulse oximetry, we're not getting from TCOM? Let's look at the science behind this. Okay, so light is transmitted from the surface of the machine, okay? And there you can see it. It's coming down green, red, blue. Okay, and depending on the color of the tissue, the way that we see color is some light is absorbed and some light is reflected, right? So you can see that in this case, the green and the blue were absorbed and the red was reflected. So on our machine, on our Kent snapshot device, can you go back one? There you go. So on the Kent Snapshot device, what we have is red, green, and blue is coming out of the machine, and only the red is coming back to the machine. And so we can measure that quantity of red. And this is sort of a simplistic diagram. It's not technically red, green, and blue, but let's go to the next one. What's happening is hemoglobin has a slightly different color depending on whether it's bound or unbound to the oxygen. And so because of that subtle color change that occurs when oxygen is bound to hemoglobin, we can differentiate based on the color of the reflected light which version of hemoglobin we're looking at. Is it the oxygenated or the deoxygenated? So we send all this light down. Some of it gets absorbed and some of it gets reflected, and then we send another wavelength down. Some of it gets absorbed and some of it gets reflected, and we can ratio those two to determine what the ratio of oxygenated to deoxygenated hemoglobin is. Now, the other thing that's important to notice is that we're using near-infrared spectrums of light. So there are other devices on the market that use visible light. The main difference is the depth of penetration into the tissues. If you're using a visible light device that uses blue light, you're really only going very, very low into the tissue. You're only getting through the stratum corneum and the epidermis. You're not even reaching the bottom of the dermis. If you go to the red spectrum, now you can get at least to the subcutaneous tissue. And if you go through the near infrared spectrum, you can get all the way past into the fatty layer. And so you get a much more accurate reflection of the full depth of oxygenation of that tissue from the stratum corneum all the way down to the subcutaneous fat. Next. Okay, so as I mentioned, the hemoglobin has a subtle change in shape when it's bound to oxygen. And this alters the light absorbing property. Essentially what that means is it changes color. And so we can ratio the two colors, the oxygenated color and the deoxygenated color, to get a measure for what percentage of those cells are oxygenated. Next. Those images come back as pixels. And so we're firing a whole bunch of these lights and picking them up in lots of different locations. And then each pixel can be repositioned where it belongs, and you can reconstruct an image. And so this is how we get the pictures that we get. Okay, next. So this is the kind of thing that you would see. So for example, in this case, we're not looking at thermography, we're looking at oxygenation. So this is a fellow that has a almost completely gangrene hallux. And so you can see on this big toe, the medial side of the great toe there is all black. That would coincide with something that has zero oxygenation. Now you can see there's a 40% there where it's kind of blue. So that means 40% of the hemoglobin is oxygenated and 60% is deoxygenated. And then if you go a little bit further into the foot, 64% is oxygenated. Now, that's good information, but what does that mean? Obviously, zero oxygenation translates to zero perfusion. And so this is a section of gangrene tissue where there is no oxygenation, and so there's no perfusion. And if there's no oxygenation or perfusion, you're looking at dead tissue. Now, the part that's 40%, there's been a general consensus that skin needs 40% oxygenation to survive. And so by extension, we say that a wound needs about 40% oxygenation to survive. The reality of it is it's not quite that simple, but it's a good rule of thumb. So you look for areas that have less than 40% oxygenation as being areas that are probably troubled, maybe leaning towards the tissue dying. Wounds that, in areas where the flow is higher, in the 60 range, 70 range, 80 range, those tissues are usually going to be fine. Okay, next slide. So let's take a look at some images and get a feel for what's going on. So we're going to go to Dr. Niezgoda, and he's going to talk to you just briefly here about how to actually collect this data and see what we see. Okay, Dr. Niezgoda, your turn.
What you doing?
Welcome to AZH Wound Care Center in Milwaukee, Wisconsin, and another edition of the Wound Care Window. In our effort to continue to bring you cutting-edge technology as it applies to the wound care field, I'd like to introduce you to near-infrared spectroscopy. This is a new technology developed by Kent, and it is highly applicable in the wound care setting. I'd like to demonstrate how easy this technology is and what kind of results this technology can bring to your practice. Here's the camera. Very easy to use. We're going to go ahead and calibrate. The calibration is performed like this. You have a white field. You bring the cursors together and shoot, just like that. You then accept the calibration, and you're ready to go. This is a patient who we have been treating for a compromised transmetatarsal amputation, as you see. The patient is now 30 sessions into his hyperbaric treatments, and he is responding in an excellent fashion. The wounds themselves show a nice increase in granulation, no evidence of ischemic compromise, and no evidence of deterioration. What I want to show you is how we have used Kent to track his progress. I'm going to go ahead and shoot a photo of his foot today. Again, you can see how easy this is. I take the camera, I align the cursors over the tissue that I want to photograph, and shoot. The camera then generates an image, and we can see the image here on the screen. What's very nice is that I can actually measure the amount of oxygenation. Here, 84%, as opposed to the duskier areas in this angiosome, 16. But this is where his wound is, and you'll see the robust perfusion and oxygenation of that distal TMA margin. Let's do a comparison of where he was prior to treating with hyperbaric. Here you see an image. We're going to drop that down into this area so we can see. Here's the area of compromise along the TMA incision. You can see that those areas have very, very little oxygenation, which correlates with poor perfusion, 35%. Again, after 30 sessions of hyperbaric, this is what he looks like today. And again, you can see the sharp contrast of those images. Look at the increased oxygenation and perfusion of that tissues. That correlates directly with tissue healing.
Okay, so I think one of the things that is really important to point out is, first off, this is a completely non-contact device. There was no contact at all made between the device itself and the patient. And that's really important, especially when we're talking about life in the time of COVID, where we're worried about surfaces. But even in general, for a wound center where infections are typically rampant and there's a lot of contamination from patient to patient possible, it's really important that you have a non-contact system. The second thing that's important to notice is when he did the calibration, there was 2 little red lights. And what happens is those 2 little red lights converge at a set point. And what this means is that your camera is always held the same distance from the surface of the wound. This is really important because when you're doing measurements from visit to visit, you know that you're getting the same exposure each time, that the changes that you're looking at are actual changes in oxygenation of the tissue, not changes in position and the way you held the camera. The third thing that I think is really important to notice about this is how fast the images appeared. I mean, this was not an artifact of video. It is absolutely correct that you can get an image as quickly as 3 or 4 seconds. And even if you do additional processing, it's less than 7 or 8 seconds to get a beautiful image. If you don't get the exact image you want, it's no big deal. You click again, there's no disposables. You just push the button and you can take as many as you want. Okay, let's take a look at some clinical cases. All right, so when we look at this wound here, this is a fellow that has had this wound for a couple of years now. We look at the images here and we see the wound itself 63% and the surrounding tissue 78%, 83%, 80%. One of the things that we know from looking at this is he's got more than enough circulation to heal this. He's got great oxygenation, not only of the wound bed, but the surrounding tissues. So what this does for us is it takes one of the possibilities off the table. We now can look at this wound fairly certainly and say, hey, this is not a circulation issue. There's something else going on here. There's osteomyelitis underneath. There is too much mechanical motion here. There are other things that are happening that are stopping this wound from healing. Okay, let's take a look at the next image. Okay, so I like this image. Now this one is actually taken from a study that we just completed. And the thing to notice here is not only the oxygenation of that central part of the wound, it's 85%, so it's clearly a well-oxygenated wound bed. Not only look at the oxygenated area of the wound bed, but look at the peri-wound areas. So if you look around the perimeter here, there's a gradual decrease in the redness from the central portion where the wound is as you move away from the wound. We call this a wispy appearance. So it's not solid bright red all around the wound. It's sort of got a cloud-like character where the edges keep getting softer and softer. So you can see the three white arrows there. You can see how much lighter, how much more yellow the tissues have become as you move away from the wound. Okay. So this is usually a sign that this wound is going to go on to complete healing. We like to see it when it has that wispiness. Okay, so this is one good way of assessing and predicting when a wound is going to heal. Okay, let's go to the next one. Okay, so this is a post-operative wound, right? And this patient had a lesion that was removed from the surface of the bone, and during that process, the skin was kind of manhandled a little bit. And when we saw them for their post-operative visit, you could see the area around that skin is starting to get a little bit of a brownish tinge to it. And that was concerning. So we did the Kent image, and what you can see is well in from where that incision is, that brown material is dead. So clinically, you can't be sure, but when we do the Kent image, we see 11% oxygenation in that central area. That skin is going to die for sure. So this is a patient we know is heading towards a slough. And sure enough, two or 3 weeks later, the wound broke open, tissue sloughed. In hindsight, and this was one of our earlier pictures, in hindsight, what we could have done is we could have seen this, and there was a couple of options that we had. We could have sent them for hyperbaric oxygen to try to get that tissue reperfused. We could have used, placed them on a vasodilator or an anticoagulant just to try to get a little bit of extra perfusion into that area. And so what we use this device for now is, again, as a predictive tool to determine when a wound is going to be in trouble. Now, this one happens to be a surgical wound dehiscence, but you could have also done this for any ulcer that seems to be struggling or floundering. Okay, next picture. So this is a difficult patient. This is a patient that had a ulcer with exposed medial malleolus. And so the patient also happens to have rheumatoid arthritis, was on low-dose prednisone for a while. So this is a tough wound to heal. As you can see, they had a split-thickness skin graft. You can see the graft in place there. And the question that we had is, how well is that graft taking? You know, this is relatively soon after application, And we want to know, is that graft going to make it or not going to make it? So what we do is we do the near-infrared spectroscopy, and what you can see on the left side, if you compare the left side to the right side, you can see on the left side there's sort of a pinkish area in the mesh, but a lot of the mesh is just plain white, and it's hard to know if there's any blood in that mesh. We look at the right image though, and we can see, especially if you look at the area around what I would call 3 o'clock, there's excellent oxygenation of that graft. And sure enough, this lady went on to completely heal. The graft took 100%. She didn't lose anything in this particular wound. Okay, let's go to the next one. This is another one with a skin graft. And when you look at this, what you can see is excellent perfusion of the graft, right? And then you go out a little bit further, and what do you see? You see hyperperfusion of the not only the wound bed itself, but the surrounding areas. You see excellent granulation tissue, and you can see the granulation tissue is so red, it's almost burgundy in color when you look at the near-infrared image. And then if you go away from the central area, you can see the wispiness again. That's our beautiful sign that we like, sort of a gradual lightening of the bright red area in the center down to a gradual sort of a mixture between red and yellow, and then the yellow wispiness, which is great. That guy went on to heal completely as well. Okay, next image. This is a Wagner 4 ulceration, right? Necrotic tissue down to the surface of the bone. And when I look at this, this is a patient that I might have suggested consider a ray resection, an amputation, because we've got necrotic hard tissue on the surface there. But when we look at the near-infrared image, the wound is much more salvageable than we would think looking at it clinically. So in this image here, there's still a very dark area at the top, but it's a very small portion of the wound. And so if you have a very small sliver of necrotic tissue, that'll eventually slough off. But if you look at the lower portion of that wound on the near-infrared image, you can see that number, 59%. Just above it, that top lip, 74%. Even the distalmost aspect of the wound, 33%. So we did not do the ray resection because we were comfortable that this wound is going to heal. It does have good perfusion. That eschar is actually more superficial than we initially believed it to be. And you can see from the picture below, he went on to improve dramatically, and this fellow also went on to heal. So in this case, the Kent image was very useful for us because it allowed us to not go forward with what probably would have been a ray resection, I believe, in a transmetatarsal amputation. Okay, let's go to the next one. So I think this is a really interesting case. What we're looking at here is a wound that has resisted every type of treatment that we could think of. She's had hyperbaric, she's had surgical resection of the base of the wound, she's had rotational flaps, she's had Theraskin, she's had Apligraf, she's had autologous split thickness skin grafts. Never heals, never heals, never heals. When we looked at the Kent image on this one, what we did is we broke it down to deoxygenated and oxygenated hemoglobin. So the typical image would be number B. And what you see is a wound that, you know, has reasonable oxygenation in the central portion. It's got this dark rim around the wound, which I think is obvious. It's like a circle, runs right around the wound. And then when we go to the deoxygenated and the oxygenated images, what we can see is that we've got a disproportionately high amount of deoxygenated hemoglobin in the center there, those sort of white islands. And this is a wound that's congested. So blood flow is making it to the perimeter of the wound, but is not getting into the wound itself. We had a vascular consult, and sure enough, this patient was throwing little microemboli and was getting ischemia in the central portion of the wound, but the perimeter of the wound was hyperperfused. So the blood flow is leading right up to the margin of the wound, but never getting the healing that we were looking for. Okay, let's go to the next one. This is a patient who accidentally kicked a plate glass door, and foot went through it. She got these lacerations, and the skin on the hallux and on the second digit and on the third digit were badly lacerated. But the thing that we were interested in was whether or not that skin on the hallux was going to survive, because it was a degloving injury. So the skin was completely flipped back and pulled off, and then stitched back down. So we did our near infrared image, and you can see right at the stitch line that the flow is poor. But if you look at the flap itself, the flap, if anything, is very, very well oxygenated. And so we were able to predict that this wound was going to go on to heal and not slough that skin. And you can see that is exactly what happened to her. Okay, next slide. This is not a wound patient. This is a patient with reflex sympathetic dystrophy. And I like this image because typically reflex sympathetic dystrophy is evaluated by thermography. We look for abnormal distal cooling as an indication of the state of reflex sympathetic dystrophy. But in this particular case, what we're looking at is oxygenation. So what we're showing is the patient comes in, they have splotchy blanching across the entire surface of the foot, and the foot is ice cold to touch. Then we do our nerve block, and all of a sudden you can see that the splotchiness has receded, and now what we have is a significant improvement, about 20% improvement in oxygenation of the tissues after a nerve block. So this helps us to understand that the nerve block for this particular patient is a very effective therapy, because we're able to prove that it actually changes the oxygenation of the tissue. Okay, next, please. Okay, so this is that case that we looked at right at the beginning, where we had the hallux that was necrotic. And I like this one because it illustrates points. So you can see that the hallux was amputated, and right along the amputation line, at the time of surgery, the percent oxygenation was 64%. So the hallux was amputated, and this stump was, prior to surgery, 64%. So should have gone on to heal, right? But let's look at the post-operative near-infrared image. That's the one on the left. So post-operatively now, look what's happened. The oxygenation has dropped from 64% to 12%. This is troubling. This is very troubling. Again, this is one of the earlier cases that we did. If I had this case to do over today, what I would have done is pop those sutures, relieve the tension on the skin. Hopefully that would have helped allow increased perfusion, and with that, increased oxygenation of the tissues. Unfortunately, though, we didn't really have a good feel for the value of the data we were getting from the snapshot at the time. And so we did nothing other than use warm compresses to the area to try to get some vasodilation. And so you'll be able to see that this model correctly predicts 12% oxygenation at the amputation site. And sure enough, this patient sloughed the entire thing and went on to transmetatarsal amputation. So let's see the next slide. So here's that same patient, transmetatarsal amputation now. And now we're very careful. We're looking at the perfusion, and with that, the oxygenation along the wound margins. And sure enough, you can see we're in the safe zone. We're well above that 40% mark. Clinically, it looks a little bit dark, but you can see on the Kent image that the percent oxygenation is well above that 40% threshold. And this patient went on to heal uneventfully. Next slide. So here's a little bit down the line. There's one little area that didn't close up completely, and we've got that little S-scar. But adjacent to the S-scar, we've got 82% perfusion. The S-scar is fairly small, 66% proximal, and so of course they do eventually go on to heal. Okay, so the last thing that I wanted to talk to you about in the last few minutes that we have here is what we call wound care without walls. Next. So with the COVID pandemic driving a significant change in the healthcare system, it's really disrupted what we consider to be best practices for diabetic limb preservation. And it's left us with a large number of patients without care. And so this is the type of technology that can easily be brought to the patient and play a role in how these patients are being assessed. This is a very portable handheld device with no disposables, no contact with the patient, and it has become very useful for doing this type of remote evaluation of our patients. Next. Before COVID, the importance of wound healing was measured at as healing at any cost. And so we had really a hospital-centric care and monitoring model. And typically we would see a 44% one-year mortality rate following a lower limb amputation. And so because of this, the procedures and the treatments that we provided really involved things like sharp debridement, invasive and non-invasive vascular tests, and advanced therapies. Now, the new paradigm where wound care is changing, the shift in the site of treatment has really moved away from the hospital, trying to get us to avoid bringing in these otherwise unhealthy, otherwise compromised patients into a hospital where they run high risk of infection, or into a private office or a wound clinic with lots of other patients being present. And so what we've really been forced into doing is doing a decentralized, stepwise type of wound management model. And so we now are relying on systematic triages, home visits, reserving patient clinic visits for the highest risk patients, and really relying on telemedicine and remote patient monitoring. So the Snapshot device really can give an excellent way of evaluating people from afar. So some of the things that you're going to get from this, and you can just go ahead and click through these, you're going to get accurate data that is very, very accurate. It's going to tell you very specifically how much is going on with regard to oxygenation and the circulation in that patient's foot. Zero patient contact, very important. No risk of transmission of infections. It's highly portable. You can hold this thing with one hand. It's got a trigger on each side, so whether you're right-handed or left-handed, you can fire the camera and grab your images. It's fast, less than 10 seconds to grab an image, and you can do it over and over again if the image is not clear or not the image that you wanted. There's no cost and no burden in repeating those images. It's so easy to use, even I can do it. Next. And you can collaborate remotely. The clinician can look at an image captured at the home and understand exactly what's going on with regard to that patient's foot and or whatever part you're examining, and their oxygenation. And you can track and document what's going on because it stores all the images. You can literally store thousands of images on the device. It has a USB port, so it's very easy to download them. You can also download them to certain electronic medical record systems. It's very easy to track, very easy to document. You can look at the changes in the condition of the skin as the wound is healing. Next. And last but certainly not least is the ability to measure the wound. So you're not only capturing a near-infrared image, but you're also capturing a JPEG image. And when you capture a regular traditional JPEG image, the current beta version of this device allows for wound measurement. And so this is certainly something that is going to be available in the extremely near future. So you can track not only the clinical appearance, but the wound size and the percentage oxygenation, not only of the wound itself, but all of the surrounding tissues as well. Okay, next. So every device has benefits and limitations. And so I just would like to talk in broad terms about some of the findings with the Kent snapshot. So there is a threshold for wound healing. It appears to be around 40%, but this is not a hard and fast number. We see wounds that heal with 30% oxygenation, and we see wounds that don't heal with 70% oxygenation. And so just like with ultrasound or x-rays or any of the other imaging modalities that you might use for other clinical applications, there is a little bit of a learning curve in interpreting the data. So in the beginning, it's fine to use the 40% as a cutoff for which wounds are going to heal and which are not going to heal. Most of the time it's great, but there is some subtleties that will become more helpful as things go by. We're looking at a ratio of peri-wound to wound bed oxygenation, and this is this idea of looking at the surrounding tissues. Patients that have dark pigmentation in their skin can be more difficult to assess because the color of the pigment of the skin, the darker it gets, the closer it gets to the color of the hemoglobin. And so right now, this is currently the only device on the market that uses this technology that can go all the way up to a Fitzpatrick 6. So keep in mind that Fitzpatrick scale is the scale that dermatologists and plastic surgeons use to gauge pigmentation levels, and it goes from 1 to 6. 1 to actually goes higher than 6, and so going up to Fitzpatrick 6, most systems can't go past a 3 or a 4. Also, there are some artifacts from surface curvatures. So this is reflected light. If you're taking pictures of an extremely curved surface, the central portion of the picture is going to be highly accurate, and the edges are going to be inaccurate because the light is being reflected in a direction other than towards the camera. So in cases where there are a lot of curved surfaces, say the front of the ankle, you might want to take 2 or 3 images, and each time moving the camera slightly to get parallel with the surface that you're interested in. Dense calluses sometimes can act as the same as if the skin were extremely thick, and so images are usually better with the removal of a dense callus before taking the pictures. Similarly, blisters and hematomas, collections of fluid on the surface of the tissues can give misleading data. And so it's just important to recognize this so that when you're capturing your image, if you see something that's unusual, that you understand the mechanics of it. And I have a question here I'd like to go ahead and address before we go to the next slide. This is, says, can we use this inpatient to monitor surgical incision for risk of dehiscence before discharge? Is there a correlation with the presence or risk of bacterial load? Not home health that I know of, but reimbursement, not in used home health. Okay, so you absolutely can use it to monitor the risk of surgical wound dehiscence. And in my particular case, I actually carry the machine up to the floor for patients that I'm concerned about, transmetatarsal amputations or even BKAs. And I carry it up to the floor, and if I see alarming issues with regard to oxygenation, and by the way, we think that we get a 7-day jump on predicting wound dehiscences. If we see discoloration and we're 7 days out, I know that that's a patient that I still have time to salvage. And so I might send them for hyperbaric, I might loosen the sutures, but I absolutely think that's a great application for this, is to look at surgical incisions prior to discharge. The other is there a correlation with the presence or risk of bacterial load? So this is an excellent question. I think in the sense that inflammation certainly increases perfusion, and with perfusion increases oxygenation of the tissue. So I think that this is certainly in the category of it probably does tell us some information about bacterial load, but the technology is too new, and I don't think anybody has good data on a precise correlation between bacterial load and oxygenation. And then these questions with regard to reimbursement, I'm going to let Pierre address those in just a moment. So let's go to my second to last slide. This is an offer to all of you. If you would like more information about the Kent Snapshot device, you can see the website address is there. Also, I would like to invite you to send me an email personally. That's my personal email at Massachusetts General Hospital. I just want to thank you. And you're going to be receiving a survey through SurveyMonkey very shortly. And I hope that you'll take the time to fill that out. Pierre, would you like to address Eric Goodman's question about reimbursement?
Yeah, sure. So first of all, thanks very much, Dr. Landsman, for that great presentation. It's always very valuable for our team at Kent to see the clinical value that you're getting from the device. And especially when you're able to get information about the wound that allows you to prevent an amputation and save a limb. I think that means a lot to the team, and we're happy that we can provide technology that allows you to do that. So thank you very much. So in terms of the reimbursement, so we are still pursuing reimbursement on the device. At the moment, we have a strategy for reimbursement today, which relies on temporary codes, but they are payable. And we'd love to work with your group to ensure that your team can get reimbursed using the device. And we're looking at more permanent solutions in terms of a permanent code, which we also require a collaboration, and we'd love to collaborate with your team to move that forward. Also, I'd like to comment a little bit about home health. So with COVID, we're seeing a change in people's perception as to what should be done at home. And we're starting to see in skilled nurses their ability to use the device to take an image at home. We recently added the ability for them to share that information with the referring physician so that they can email the images and some other additional information out to a referring physician or a wound care doctor to assist with the treatment protocol. And we see that likely happening more and more as the impact of COVID really hits the wound care community.